hospital's performance or its protocols or its own opportunities to do better, right? And then some of
Yes.
it can be due to system-wide issues. Like if we don't have post-acute care, we don't have a place for long-term care, that's harder on you. Do you have a sense of how much of this, I appreciate your honesty and candor. It's so important because we can't solve it without it. But how much of this do you have a sense is, opportunity where UVM could do better versus the what I'll call system-wide failures here in Vermont?
It's honestly a mix. So here's another example. So one of our big issues for pressure ulcers is we realized about 6 months ago that our wound care nurses, we have specialized, highly trained wound care nurses who constantly round on our patients who are bedridden or are very high risk for getting a pressure ulcer. And they're amazingly good at helping prevent that. Well, we realized as we saw a little uptick in pressure ulcers that wound care team was spending lots and lots of time on patients who were admitted with xylazine wounds from substance use disorder. And so we did not have enough wound care nurses to meet the full inpatient demand for that, which was a combination of things. It was people staying longer in the hospital. It was a new problem that we were learning to address better.
Mm-hmm.
And we had to react to that. So then we had to figure out how to budget for that mid-year. We had to hire those nurses. And then we had to get them going both on the wound care for substance abuse disorder, xylazine wounds, which are devastating, and also on pressure ulcers. We also went back and looked at our leadership teams on each floor and asked them to take more of a role on pressure ulcers because many of them have long stay patients. So some of that's on us. We're not recognizing it maybe quickly enough. Some of it's on, we have more substance use disorder with a new wound problem. And some of it's on the Vermont not having nursing home beds. So we're having 75 people here that really shouldn't be here and trying to manage nursing home patients in an acute tertiary care hospital.
Okay, thank you. That was helpful. It's interesting. So much of this is really quite broader than just this budget, but this budget sort of encapsulates so much of what we're dealing with as a state. So, and then the second one is value-based purchasing and readmissions penalty. I'm not familiar with what that is. What is that?
Judy, can you exactly explain that? It's tricky and I don't want to get it wrong. Maybe Sunny can, he when it came off mute.
I can take a shot at it. And I'm again not an expert in this, and we could actually get someone sworn in if you want as an expert for the future, or put it back to you in writing. But so CMS has a series of goals or performance measures that if you deliver on those performance measures, then you qualify for value-based purchase. They call it value-based purchasing. Because they're purchasing the care from us, as opposed to, it's not like we're buying things and selling things. I don't want you to get the wrong idea, but it's called value-based purchasing. And so so you can either get a reward, and it depends on the time of the year. I'd be shocked if UVMMC never had to pay a penalty before, because these go back and forth, quite frankly, depending on what you're looking at on any given year. And so you can get a reward for performing in one year. And so your reimbursement can be a little bit higher on your Medicare patients as a result of the performance, or you can be a little bit less depending on that particular measure. So here, I don't know specifically what the readmission goal was and for what patient criteria it was, but clearly we didn't hit the readmission criteria. So I'm going to make it up just for the sake of argument, just so you understand it. So for colorectal surgery, it could be that the readmission expectation is 5%. If you're between 4 and 6%, there's nothing. If you're greater than 6%, you might have a penalty. If you're less than 4%, you might actually get a little reward in your overall value-based purchasing scale. Does that?
Yeah. No, it's very helpful.
Okay.
It's very helpful.
It might not be perfect either. Yeah. I want to just say, but
the reason I'm confused on this is because our overall readmission rate we know is very low. So so there's some specific area we must have missed on. I recall it might be either pneumonia or COPD, but or CHF, but overall our admission rate is really quite good. So we'll have to get you the exact, it's one category, as Dr. Eapen said.
Yeah, they usually, and those categories can change. CMS will change them. So it might be particularly, it's not our overall one, but it could be just like you said, for COPD or for pneumonia or a particular kind of surgery that they've targeted for the next couple of years, and then it'll change to something else. But yeah, whatever it is, we typically, when you're in the quality world of this, so it's usually the CMOs and the chief quality officers, they identify this and then they go after it to say, okay, what do we need to do? Just like Steve described for those pressure ulcers. So here it would be targeting those patients and understanding, is there something different that we're doing? Is there something different that that particular service is doing? What's happening on those floors? That's the work that happens here. And it really is, the goal is to, how do we improve quality? And I'll just point out, like when Steve talked about the pressure ulcers, he didn't say, hey, we need to make more money, and so we're going to hire these nurses. It is, we need to improve the quality of the care that we're delivering to these patients, and we have a unique situation, and we need to hire more nurses to get there. And it's like, that's the cost of doing business, because we're trying to do the best that we can. But you could be pretty targeted about where you want to go. We're always making those decisions about, where do we want to put those extra nurses? Can we hire those extra nurses? Can we afford it? Is it worth it from a financial point of view, or is it driven that the quality is going to suffer and we really need to take care of that? Those are real life decisions that we're making all the time about quality and safety and reimbursement, quite frankly.
And then the Medicare Stars ratings, are you familiar with that? And can you explain what that is to me?
Yes. So CMS Stars rating, CMS, all hospitals take Medicare patients, get a star rating from CMS. It's based on the safety of care delivered, the quality of care, patient satisfaction surveys, and every hospital gets a rating from 1 to 5.
And what's UVMMC's current rating?
We had been 5 for the 3 previous years. We just learned in July that we've gone to 4 this year. It's actually some of the same story that we're telling you. The health acquired conditions heavily weigh in on that ranking. CMS Stars definitely has 22 and 23 data in there. So we're seeing that time when we had high level of travelers, high turnover of staff, sicker patients, a lot of COVID. You have to also remember, I've seen a lot of academic medical center data. I was at a big meeting last year where during COVID, when we weren't letting families visit, patients were getting out of bed less, and that led to an increase in pressure ulcers. It's stuff like that. Your visitor policy actually, and there was less falls and more pressure ulcers. So our star rating also, we are working hard to regain our 5-star status. We're very proud that we were for 3 years. We're 4 now. 100 medical centers across the country went from 5 to 4, but we strive to be a 5-star institution.
And you said it was the current star rating that you just got was 4, and that's based on 22 and 23 data?
It has a lag to it, yes.
Yeah. And do you have a sense of where things are currently in 24?
So it's a little hard to project exactly. We have to digest this bubble of the pandemic. So I hope we will stay at 4 stars, but it depends on what happened. And I don't have the exact number. I've seen some data that shows that we may stay 4 for a while before we get back to 5, because it's a 3-year running total average.
Okay. All right. And then the next slide, Kristen, if you would. This is I just pulled this, the Leapfrog. Do you guys participate in the Leapfrog studies?
It's a paid survey, so we do not. You have to pay to have your data in there and be, so we do not participate.
Do you follow the Leapfrog surveys and results?
Not closely.
Okay. And this indicates at least Leapfrog downgraded the medical center from 22, 23 to fall of 23, spring of 24. Do you review this data at all?
We don't review Leapfrog data. I would, if you made me guess, I would bet it's related to what we've just talked about on the previous 2 issues. It's around health acquired conditions.
Okay. All right. I'm almost done. Thanks for bearing with me. Shifting gears just slightly, the health network. I understand, Dr. Eppen, you work for the health network. Your salary comes from the health network, right? Is that correct?
That is correct. paid through the University of Vermont Medical Center, but reallocated out to all the other hospitals.
Right.
Yeah.
So each of the hospitals in the network pays a portion of the network folks' employees' salaries.
That's right.
And they do that through the transfers. Is that right? On the financial statements, that would be in the transfers to the to the health network.
Rick, can you help with that? Because
Yep. So the way that we do so there is the vast majority of the administrative shared services, including Sunny and myself, is borne by the UVM Medical Center. And actually, it may be helpful we may want to pull up another slide, Chair Foster, from our presentation to kind of help explain that. So Elliot, I don't know if you're.
I think that's okay. I think I'm
Okay.
familiar with that one. I want to make sure I give the others their time. So just a couple quick questions on the shared services. And I didn't put this in my slides, but the health network administration, the number of administrators, FTEs at the health network went from 29 to 47, and the salary increases, the expense went from 20 million to 27 million. So a 61% increase and a 45% increase. Can you explain why that's growing and what it's for?
Do you have the slide there, Chair Foster, that you could pull up, or?
I don't. It was in the, let me see if I can find it. Reference the document. It was in the submission. UVMMC Network Shared Services document.
Yeah, I'm not seeing those numbers, so we can follow up in writing to that. You're looking for what is the change there from one year to the next?
Well, you provided that from 24 fiscal year to fiscal year 25, and I was trying to understand the growth and what the thinking was behind the growth. So from 29 employees to 47, from 24 to 25, and 20 million to 27 million. And why is the administrative function at the health network growing?
Yeah, so again, we'll get you concrete explanation of that, but a piece of that which we did highlight on our slide that I was going to actually have you pull up is that we do add things to shared services that are not incremental adds. Obviously, that's less and less now that we've built out our shared services. But I'll give you an example. Say there's 10 people at the UVM Medical Center they've been traditionally supporting the UVM Medical Center, but then their roles change to support the entire network. We pull that into the allocation model to say those 10 people now, the UVM Medical Center should not be paying for the full share of that. That needs to then be allocated out to all the partners that make up the UVM Health Network. So that increase, there may be a piece of that's actually not an incremental increase. That's actually a transfer of what was a hospital specific cost that's now become a network shared cost.
Okay, a breakdown of that to the extent it's just a reallocation versus a growth would be helpful in the follow-up. And then similar question, the PHSO, Population Health Services Organization, shared services, the number of FTEs went up 21%, the total expense went up 52%. Can you provide some color around why that's expanding?
Yeah, that for sure. A big piece of that is transfers into the shared service, so we can provide follow-up with a breakdown of that as well.
Okay. Okay. Why don't we stop there? Thank you all very much for your attention and your answers. I appreciated it very much. So we'll take a lunch break here and then we'll come back with board questions. Dr. Eppen, how long would you guys like for lunch break?
should we come back at 2 or is that too
Perfect.
long? Is that too?
That's great.
Great.
No, that's good. All right.
Thank you.
We'll come back at 2 o'clock. Michelle, we'll go off the record. We'll see everyone in 46 minutes.
Okay, we're off the record.
Thanks. Michelle, are you back?
Yes, I'm here.
Great. Dr. Epen, do you have everyone you need?
I, I think so. I think we're good to go.
Okay, great. We'll resume the Green Mountain Care Board's hearing of August 28th. We're in board member questioning, and I'll turn it to board member Holmes for any questions she may have.
Great. Thank you so much. Thanks for the presentation this morning. I learned a lot. I learned a lot through Chair Foster's questions and your answers. There's so much information here that honestly, I still have a fair number of questions. So hopefully we can get through them all. So I want to start with a couple of very quick, I hope, clarifying questions, and then I'll get into a little bit more of some substantive questions. One quick question in slide 28 of today's presentation. That's the slide that looks at the NPR growth adjusted for population change. Does that slide incorporate the newly revised NPR that includes the increased rate submission?
Member Holmes, no, it doesn't.
Okay. I would love to see that calculation if you can submit that.
Absolutely.
Okay. On page 19 of the narrative, there's a table there which has the gross patient service revenue broken down by inpatient, outpatient, and professional. Do you see that page, just so I know that we're all on the same page? Big chart. That's the one. Yes. There is a line in each of these which has chief executive officer. There's a chief executive officer line on inpatient. There's a chief executive officer line on outpatient and also on professional. And if you total it up, it's like $16 million. I'm wondering, what does that line mean?
So I don't know if Judy's back on, but Mark, I don't know if you know what services, these are roll-up categories, Member Holmes. So there's obviously Sunny's not generating $16 million worth of.
No, I didn't think he was. I was trying to figure out what that was. So, and I would,
Mark,
and I would assume that's Dr. Well, I don't know who that is, but.
Okay, so we'll just follow up on that. I mean, this is in our hierarchy of cost centers that might roll up through the leadership oversight structure versus what's purely clinical and what's purely administrative. But we can easily get back to you on that one, Member Holmes.
Okay, that was an odd entry. I couldn't understand it. And then another quick one, hopefully. See, we're getting through these quick ones. Looking at the income statement, pull that up so that I have it. In 23, looking at non-operating revenue. So in fiscal year 23, looked like UVMMC earned $55 million in non-operating revenue. And then in 24, you're projecting $53 million. And then in 25, it's projected only to be about $20.6 million. So I'm wondering what accounts for the significantly big drop in non-op revenue.
I can start. I think that the largest category there, and we can provide more detail, Mark, unless there's something you want to. The biggest item in there is investment income. So that's essentially us making for the 25 budget. It's us making a projection on how much we believe we'll earn through our investments.
Okay. So there was a separate document that had a little bit of a breakdown of non-operating revenue, and I was trying to follow the numbers here. It does have a line for income from investments in 24 of about 18 million. And then for 25, it has 145,000. So is that what you would be talking about in terms of the differential there?
Actually, would you be able to pull that up, or if you give us a document, maybe we can
It
pull
is
it up.
in the other revenue Excel tab. I can't pull things up right at this point. There's no way I'll be able to do that, but it's in the other Kristen, if it's possible for you to pull up, it's in the other revenue worksheet tab on our website. We could find that there. I'm trying to understand where these numbers are coming from because it's a pretty significant drop and difference.
Member Holmes, what's the name of the document?
Rick, I can speak to that quickly too. Our assumption on investment returns is a 4% return in all of our budgets. It's either 3.5 or 4% return, and any decline is just the actual return was greater in that specific year. It is literally, that's the explanation.
Okay. In the narrative on page 30, it says that $21 million has been budgeted for anticipated investment income for UVMMC. So I'm trying to figure out where that might be.
We would have to see the exact document, Jessica. I can assure you that that is what our budget assumption is on investment return.
21 million or 145,000?
4%. I can't speak to the exact number that you're looking at, but I can tell you our assumption is 4%, a 4% return on our investments.
Okay. Maybe I don't want to, we have a lot to ask today. So I guess I would just ask if somebody can follow up, maybe our team can follow up with what I'm looking at is the document of non-operating revenue. And then I'm also referencing what's said in the narrative, and I'm trying to pull those two together. So that would be helpful. I also, in terms of general contributions, it looked like there was 158 zero budgeted for 25, but there was reference to about 4 million expected in donations. So I'm trying to figure out where all these things line up to the non-operating revenue from what's said in the narrative to what I see plus the declines. So maybe we can parking lot this and ask for some further clarification. I think that might make the most sense. It's hard when we're all looking at different documents, I know. So, okay. Just another quick question on some of these documents. The balance sheet, I was trying to understand the projections for fiscal year 25 in the current assets area. And it looks like you're assuming the exact same patient accounts receivable, exact same allowances for uncollectibles, and exact same due from third parties in fiscal year 25 budget as is projected for 24. Other hospitals, as I looked at it, seem to assume some growth in those areas, presumably linked to projected growth in NPR. So I'm wondering why the network doesn't also do that and how that might impact your days cash on hand projections for 25.
So again, I just want to make sure. So it looks like the document you're looking at, Member Holmes, is the numbers are not changing. Yeah, the numbers are not changing. Oh, it looks like Kristen's pulling it up. Thank you.
Yes, thank you. That's perfect. So see how in projected it goes 267, 190, 625, and then in budget for the following year it's exactly the same. So that actually drops down to current assets, and so I'm trying to understand that, given that those lines tend to grow over time and would be linked to the NPR for that year. Then just looking at what other hospitals have done, they've assumed some growth in those. So I'm also just trying to understand why the network does that differently.
Member Holmes, we don't model that growth, but to be clear, where there's two projections that you need to provide here is that you need to do since this is a balance sheet projection, it goes from year end to year end, is that you would need to project where you think your 24 is going to land and then where you think your 25 is going to land. So because of the two variables, we just don't do that projected with the budget calculation. And so that's why it's the same number.
Okay, that does seem unique to the network hospitals. I'll just say the other hospitals have projected some growth in those areas, so that would presumably fall to that current assets line. Well, and then, right?
I mean, if we look at the variability there between the years from 2021, it goes from 220 million to 224 million, close to the same number. It went up a little bit in 23. The 23 or 24 projected is slightly lower than the 24 budget. So any variation in that number, even if we just go back on past trend, is probably no greater than 10%. So I mean, it's just so hard. The hardest thing to project is a balance sheet number based upon two year-end projections. I will say that. Well, so that's why we don't do it. I'm not saying that it's the best way to do it. I'm just speaking to that's how we did it.
Okay, but if those do grow, would that affect your days cash on hand projections?
Yes, assuming all of the other numbers stay the same.
Great. Are there any, this is my next question. I think you can pull down, Kristen, that slide. Thank you. I don't think I need to pull up any other slides. Those are just my clarifying questions. Are there any updates on UVM's efforts to get that retroactive adjustment from Medicare that was commented on in the narrative? Any updates on that? The last 3 years that didn't keep pace with inflation? I know there was some, it was on page 13 of the narrative. I can read the sentence. If we are
Yeah, yeah.
successful in getting a retroactive adjustment, depending on the timing, we would reflect it in this year's or next year's commercial rate request.
Yeah, that was provided just as an example, member Holmes. So what we're saying there is we're advocating for Medicare increases, but we haven't. There's nothing, unless I'm reading that wrong. There's nothing active that we're waiting for some sort of determination from Medicare to increase our Medicare rate.
Okay, I thought that there was something active if we were successful. Sorry. All right.
So,
Perfect.
Sunny, excuse me, member Holmes. Sunny, is that your advocacy in Washington, D.C.?
Yeah, I think we've tried to hit on multiple accounts, member Holmes, on that because of the unique rural situation that we're in, that we ought to readjust that, but we have not made any progress on that.
Okay.
So
I
we'll continue
wasn't
to
sure
try.
if there had been something between the time of the submission to now that suggested you may get some retroactive help there. Okay. And so I'm going to turn, I think my next sets of questions are really involving some of the evidence that you submitted around UVM's low cost and their efficiency in both the narrative and then again in the presentation today. It's really important to my decision making, so I want to spend some time there. If you could turn to pages, say it's mostly 13 to 16 in the narrative, but some of these charts were reproduced in the presentation today. But this is where, again, I think there was some focus on evidence about clinical efficiency. So I really want to understand what's happening in these graphs and these tables. The first table is, you have this chart of expense per adjusted discharge. And then on the next page, you have the expense per adjusted inpatient day. There's similar analyses, so I'll just focus on, thank you, on this one, on this chart 9. Kristen, yeah, perfect. And this is expense per adjusted discharge benchmarked against teaching hospitals that you submitted from the AAMC COTH data. I think it was also in the slide presentation today. So the way I look at this chart, which may be different than the way you looked at the chart, but the way I looked at the chart is that in Q1 of 2021, UVMMC was well below the 25th percentile, right, at about $15,000 per adjusted discharge. The 25th percentile for hospitals was $20,000. And then by the end of 2023, at the end of that chart, UVM is slightly above, or let's just call it at the 50th percentile, at about $25,000 per adjusted discharge. So that's a 67% increase in expense per adjusted discharge in just like 3 years. So I'm trying to understand if you can explain how UVMMC went from below the 25th percentile to at or around the median for teaching hospitals in such a short period of time, given that actually the 25th percentile for teaching hospitals stayed about the same at about $20,000. And even the median stayed about the same at about $25,000. So it's a very large change in UVM compared to other teaching hospitals. And I'm wondering if you have a sense of why UVM's expense grew so much faster than other teaching hospitals.
So I can start, but feel free to jump in, Steve and Judy. So one of the reasons is what we highlighted actually even in the slide where we were looking at Medicare cost coverage. So for us as an academic medical center, we certainly have had to employ a lot more contract labor than other parts of the country, and you really saw that in our wage index, like our internal calculated wage index that was on slide. I'm just getting to the slide here. Just take me a minute. Started on slide 41 and 42 of our presentation. So because of our rural nature, we've had to keep, all the services going. We've had to incur a lot more contract labor than many of the AMCs across the country. We've also had to do some pretty significant salary increases to attract and retain staff. That's escalated certainly a lot more than some of the other AMCs across the country. I would say New England was particularly impacted, but we're impacted even more because we're even more rural and more competing for talent, and getting people to come here has been a struggle. So we've had to it's really the cost of our labor force that is driving that number up.
Only I would add, Rick, is member homes length of stay has a big impact as well. So the cost of care increases as length of stay. And we had huge issues through that time with getting people out that isn't reflected at all. Many AMCs in the country have a much better system for getting people out of the academic medical center.
Okay. So do you have, it looks like you have this benchmarking tool. Do you have benchmarking tool on that contract labor, being disproportionately higher at UVM, salary increases being disproportionately higher, or turnover rates being disproportionately higher? That would sort of support that explanation. That would be helpful.
We can follow up with that.
Okay. And as things start to settle, is there an expectation? Do you have a percentile goal for where you would like to be on this metric in terms of, relative to other teaching hospitals? What percentile? You're at the 50th now. Is there a hope that you'll get back to the 25th percentile?
I'll start. So, we want to be as cheap as we possibly can be and be high quality and safe. I will tell you that in the last 3 years, we've seen a lot of wage growth. It's expensive to live in Vermont now. Housing is expensive, food is expensive. And so the wages that we are paying our staff have gone up. It may be hard to get back to 25th because I don't think it's the 25th percentile to live in Vermont right now. And so I think that's really reflected in what we pay people to work here.
It's just such a significant number. I think the back of the envelope calculation, and I might be incorrect about this, and it is truly back of the envelope, but if UVM had stayed at the 25th percentile, I think you have about 50,000 adjusted discharges a year. Does that sound right?
More like 25,000, 23 to 4,000,
Okay.
I think that's right.
I was pulling it off the NASHP,
Yeah.
so I might be wrong, but the differential on that many discharges at $5,000 per discharge is significant and would have a significant impact, obviously. And we can do the math. You can do the math on how much would be saved a year. It's at 50,000, if that was right, at 5,000, it's $250 million a year, right? So if half of that is right, $125 million a year, if the adjusted discharges is only 25,000, we're talking about a significant reduction in what the commercial rate need would be. Am I right?
Yeah, no, I'm gonna trust your math. But I wanna come back and emphasize the two things that maybe Steve said that are really, really, I'd love to have a really, really significant. I think the challenge for us in Vermont today that wasn't there even 4 years ago is that we actually got a discount on being able to hire clinicians in Vermont. People were willing to get paid less to come live in this beautiful state at a lower cost of living. And today, when we're recruiting the docs that we need, it's just the opposite, that we have to pay significantly more to get them to come out and live here because the supply demand piece has really, really changed. And our non-physician market similarly has just gone up by so much. And we're seeing that in every one of our hospitals, but UVMMC in particular, from our nurses to our other support staff they've just gone up so much. I don't think it's going to come back down. So our goal would be to, how do we change the model of how we provide care, so that we don't rely on those folks as much and to get productivity, and then trying to keep it as low as we can, like Steve said. So I think it is really different, just coming from Massachusetts to Vermont, and the difference today in our recruitment, that I could tell you, it is a different marketplace. And unfortunately, that we are now competing in a national marketplace. Certainly for travelers, it's a national marketplace, but for even our own nurses, that people are looking, they're looking at that market and looking at where they can find jobs, and they're looking all over. And for physicians, it's even worse. So that's the biggest challenge. And as you know, our biggest part of that expense for us, that's different from other people. The biggest part is our workforce is very, very high, and it's the biggest part of our expense overall. So I think your question is great, and I'd love to. And so I want to give you credit, because I didn't think about it. I'm just proud of the fact that we're between those two numbers. But you're right, and so I think there's value, and we'll have to. This is an internal work that's long term to say what were the components of that went up the most, and can we target that? That's a great question that we hadn't really thought about. So I appreciate that as well. So thank you, Member Holmes.
And let me just ask you on that point about, you said that you're competing on a national market. What is your target benchmark percentile that you're trying to hit in terms of salaries?
It's too low. So I think we try to pay at the 50th percentile, 65th percentile for people that are in these, what we would say are really high demand. So if you're looking for radiologists, anesthesiologists, gastroenterologists, and we have been striking out. We're going through the process. We've dedicated a lot more resources to it. We're bringing them here, they're interviewing, and then we're striking out on them. And so they're getting better offers. And so what we've realized is we're not paying enough, or we're not paying in the way that we need to. So it's a great question, and we are putting a lot of effort into that. We haven't found the quotient there yet.
Okay. Related to this, when I looked at this number, then I was seeing, the median for expense per adjusted discharge, pretty close on both measures. I saw it at about the same time I saw your press release on August 7th, related to that, trying to increase the federal understanding of rural health challenges. And in that press release, the health network stated that UVM Medical Center is in the lowest cost 25% of academic medical centers nationwide. So I was wondering what data that was relying on and how that relates to this data.
I don't know who wants to take that. I know it's a different benchmark. The Council of Teaching Hospitals is different than the Academic Medical Center one, but so we'll have to bring that back to you on that benchmark on the Academic Medical Center one to do the cost comparison, but it's a different group of hospitals.
Okay, yeah, I would like to see what that is referencing, how you're measuring costs there. That would be helpful. Thank you. Okay, the next, in that next chart you had, the hospital operating costs per adjusted discharge there is a different way. This was relying on the NASHP hospital tool. So this is on page 14 of your narrative, and I think it was also on a chart today. I was just curious how you selected the peer group for that chart. Yes, that's the chart. Kristen, you are good. If this is Kristen navigating, thank you.
Yeah, so we, because the board has been using NASHB data, we wanted to at least have some NASHB. Again, we're trying to present multiple different benchmarks,
Right.
not just one. And so having some NASHB data presented, we felt it was important to do as well. And so we picked some academic medical centers that that were in our area. We used I think actually it was the Green Mountain Care Board staff that put out the NASHB, the source data of the NASHB data, and we just picked and chose some so that we could at least have some NASHB comparison in the presentation.
That's helpful. I just, because I was trying to pull all this together, and so then I also looked at the list of hospitals that were on page 16. In your chart there about, this was the chart that I think there was some reference to in today's presentation, comparing the clinical to admin salaries. So it's a different set of hospitals in that peer group. Was there a rhyme or reason to the different? Some of them are overlapping, some of them are different.
Yeah, it's probably worth pulling up our presentation because we obviously spent a lot more time since we put together the narrative to look at this deeper. And so if you start at looks like it's probably slide 43. No, sorry. Peer group. Yeah. Okay. Slide 44. So this, we've refined our kind of our looks at the different peer groups, member home. So this is the Green Mountain Care Board peer group looking at that same data that was in the narrative, looking at the NASHB data, but adjusting for the fact that the home office cost report isn't reflected in the NASHB data. So this is the Green Mountain Care Board peer group, the UVM Medical Center at 25.3, and the average of that peer group at 37.6, and the median at 27.7. If you flip to the next slide, we also used the Tom Rees 46 AMCs to see if there was, did that tell us a different story? It didn't. You see the same, the same delta there as well.
Yeah, I think there's so many different, every slide has different, or, there's charts with different hospitals. And so I didn't have this slide deck when I was looking through the narrative. All I had was, the narrative at that point. And so I'm just going to make a comment and I'll move on, but which is that if you included the hospitals that you had on page 16, in the table on page 14, actually, UVM is above the average. And so the hospitals that are included in page 16 all have, most of them, 4 out of 5 of them have lower hospital operating costs per adjusted discharge. So it's really just, I think at some point, we're going to have to all agree on a peer group that we can use and continue to use, because different hospitals on different charts makes it really challenging to figure out what is the appropriate comparator group. So I'll just move on from that, unless you have something.
Yeah, I couldn't agree more. And I think we did start to have some discussions about the peer group. And I think before we get too deep into planning for next year's budget cycle, I think that just coming to consensus on that, I think would be very helpful.
Yeah, and I think we should be able to do that, because there's too many different hospitals and they're different on each table and chart, and it's just hard to know who really we should be comparing the medical center to. On the NASH piece, so there's multiple ways to start to think about efficiency, and some experts say, and I think there's disagreement that I've heard from hospitals, but that efficient hospitals should be able to manage at or close to Medicare pricing. And so one way that NASHP attempts to look at some of that is to look at break-even commercial prices, right, in the NASHP tool. And so I'm just wondering, UVM was among the highest in Vermont. And actually, if I look at those 16 hospitals, I combined both the hospitals that you had on page 14 and the hospitals that you had on page 16 to put a comparator group that UVM feels like they should compare themselves to. And UVM was actually, the only hospital of the 16 that required a commercial price over 200% of Medicare to break even. Most of those other hospitals, the median for those hospitals in these 16 was 149% of Medicare. So I'm wondering if you can just speak to that measure and how, you think about it.
I'll start. Once
Yeah.
again, this is from a doctor speaking to an economist, but Medicare reimbursement rates are not the same for every hospital. There's
Right.
real variability in what's in the denominator. It makes a
Mhm.
giant difference. So some of our peers around us get significantly different dollars for a Medicare case than we do. And so that's one of the huge problems with using percentage of Medicare as the tool to compare. I'll stop there. Now I'll divert out the more the
And that's the
finance
same,
people.
that's the same concern you have for the RAND pricing using the relative pricing, right? It's the same concern.
Medicare pays differently to different
Okay.
hospitals.
But I did hear you say with the Seoul Community Hospital bump that you received, that should level the playing field to some degree with the other hospitals. Yes?
Getting closer.
Yeah.
We're still,
So
wage index.
Yeah, would you expect that, in fiscal year 23 and 24, that UVM will be closer to the median break-even commercial price?
I believe we do. I
So-
believe that.
Actually, probably should let Judy answer that because
Yeah.
she did spend a lot of time on looking at that data, member homes, and the cost coverage. I think she can speak to and where we're headed.
Right, so you can see that when I reference that information, let me try to find which slide that is. Apologies, let me pull that. Starting on 41, 42, you can see that the variation in the the payment to cost ratio is impacted by, a few things. What area wage index that we are subject to. So again, we had that period of time when we were under the Boston wage index, which more closely aligned with, at that time, what the wages were coming in for the academic medical center. And then as we no longer receive the Boston wage index and our wage pressures continue to go up, that's when you see that you can see the 23, it has the largest gap in the average hourly wage, but you can see that the coverage gap actually gets smaller. So we move from 75 to 80.61%, even with a wider gap. Thank you, Elliot, even with a wider gap in our wage index. So we are making those improvements. That Seoul Community Hospital payment impact is making a difference, and you're really seeing it show up in 23, 24, and 25. What we do not know is where the wage pressures are going to go in the future. So I made the statement previously that if wage pressures start to settle, we're going to see our and when the 4-year catch up of the area average hourly wage index starts to catch up, you would see those numbers get closer in terms of coverage, which would put us closer to the commercial number that you were mentioning on the coverage that would be needed. So we are working our way towards that. We are cognizant of it. And, obviously the future, we'll see what that brings, but we are focused on that as well.
Okay. I think that's something that I'll be looking at in the future. using that NASHP tool to see how close, once we identify what the appropriate peer group is, how close is UVM to coming to the median break-even price. So just, I think it's an interesting metric to be following. I'm kind of going in order of the narrative today. So on page 15, there's this Centillus data that I also believe was on one of your slides. This was, I guess, a different peer group. This was, I understand from the Q&A pre-hearing questions, it's benchmarking academic medical center systems with more than 500 beds. I just had a couple of quick questions about it. This is about the health network as a whole, so not really about efficiency of UVM Medical Center per se, but I understand it's a useful exercise to look at. And I wanted to understand what the footnote meant that says Centillus General Admin benchmark reduced by 25% to account for executive teams not in network shared services. So it sounds like you've taken the benchmark and reduced it by 25%. Can you explain that? Or maybe I just don't understand.
Yeah, so that benchmark is actually higher for that particular category, but one of the in doing
just
any
one
of the
category? Okay.
Sorry?
Maybe I'm not. Is it just for one category that happened to?
Yeah, it's just that one category that the second to bottom line there that says UVM admin DEI development medical group. That's the one that was
okay.
reduced. And it's to account for the fact that, again, these benchmark services, you have to spend some time to make sure that you're creating an apples to apples comparison. And we believe some of the clients have their local admin, their C-suite costs, for example, that they would have Steve and Judy in their numbers. And so to be transparent, we wanted to make sure that we reduce that benchmark by an amount that we think creates a more apples to apples comparison. So that it's that 4.5% that we reduced. And as we continue to work with Centillus, we're going to continue to kind of refine that particular line to make sure it's as accurate as possible.
Okay. Yeah, it might be helpful just in probably future submissions if there's more information that you could provide on what these categories are, what sort of just a little bit more about the Centillus report, just so we can understand it. It's a little bit hard to follow here. I'll just give you another example. The health network external relations looks like it's linked to marketing. Does that mean that the health network is spending $10 million in the fiscal year 25 budget on marketing?
No, it doesn't. And that's again what we have to line up the categories, and they don't, so Centillus doesn't, for them marketing is, communications, external relations, all the things that we consider external relations internally. So you have to line up those categories with the types of departments that you have internally. So that the $10 million is not just marketing; it's our external relations folks and our communications team as well.
Yeah. Okay. It's just hard to make sure that we're really looking apples to apples without some of the deeper detail on this, but I appreciate the effort. Okay, there's been some discussion around admin versus clinical. I need to dig in a little bit closer into the material that you sent and the NASHP report and the different categories of management and admin labor costs to understand what those adjustments are. So I'm not going to waste time here, but I did want to ask a quick question about, I was looking at UVM's submitted staff FTE breakdown for both 24 and 25. It looks like on average, it looks like about 3% increase in staff size over from 24 to 25, but there was one area that seemed to have a huge increase in staffing, and I wanted to understand that. And that was medical group administration. So it looks like you're budgeting for an increase in that medical group administration. On the clinical FTE line, you're going from 88 to 122 FTEs, about almost a 40% increase. And then on the non-clinical line, you're going from 131 to 160. And that is in that category of medical group administration. So I'm wondering if you could help us understand what's driving the large growth in that administrative category for 25.
So Member Holmes, would you mind just pulling that up? Just want to make sure that we're
Yeah,
responding
let's
to
see.
the.
Oh, there we go. Medical group administration, right there, 88 to 122 and 131 to 160.
And can you actually just scroll up so we can see what the column headings are?
Mm.
Are these physician FTEs, staff FTEs? It's hard to tell.
I don't know. This was just one of the documents that we had in our in the submission, was basically a breakdown of all your employees, all your staff, and the growth from year to year. So I just, that, for the most part, it looked, if you look even just at the sheet here, right, there's not a lot of change from 24 to 25, except in a couple of categories. I'll say this was a big category that had big change. And then there was another social services was another category that had a big decline. So I was surprised by, frankly, both, but this is the one I'm focusing on here, given the conversations around admin and clinical. Looks like it's all in admin.
Yes. So the fact that it's labeled clinical FTEs and non-clinical FTEs, this must be physician FTEs, because we wouldn't create that delineation for staff positions. So let us give you so this isn't the cost center may be listed as medical group admin, but that doesn't necessarily mean that that's administrate, and it's definitely physicians. It's not staff because of that. But we'll get you the breakdown of what that increase is.
That would be helpful. Thank you. And so again, thinking about staffing and all those challenges therein, I know Dr. Epen stated in his opening remarks that labor is the largest expense. So another way to think about hospital efficiency is to look at how effectively labor resources are deployed. So the way I, as an economist, would do that is I look at clinical productivity. Hence, that's part of the reason there was some questions in this year's guidance about clinical productivity, trying to get a sense of how effectively an institution, a facility is deploying their labor, which is the most expensive resource they have. We can pull it up or we don't need to, but a back of the envelope quick look is about 40% of the practice areas that you have listed there have clinical productivity rates that are at or below the 25th percentile, and another third or so are between the 25th and the 50th. So the majority, like about 3/4 of practices, have clinical productivities that are lower than 50% of peer practices across the country. So I'm wondering if you can talk a little bit about, explain why you might see clinical productivity relatively lower at UVMMC than similar practices across the country. And since they're benchmarked, I'm looking for factors that are unique to UVM and not experienced elsewhere.
I'll start. So one of the big challenges for our clinicians is we haven't given them all the support that they need to be basically seeing patients all the time. We haven't given them the full support staff that they could potentially use. We worked hard on that this year. And also we haven't had all the tools fully implemented in Epic, electronic medical record, et cetera, so that we make sure that our clinical schedules are completely filled. So in the past, if someone canceled at the last minute, we had no way to pull someone in. So we've done tremendous work over the past couple of years to improve the support for our physicians with tools like, you may have heard about it on the news, that a bridge, which is helping people dictate in real time, so they're not dictating for 3 hours at home. We've added pieces in the office to make sure that patients are getting in the rooms, getting settled, getting all the accessory stuff done so our providers can see more. In 23 and 24, we ran sprints and did a lot of work in our operating rooms, in radiology and laboratory to improve efficiency and productivity there. And I do believe that we are much more prepared to see productivity really increase in the outpatient setting, which you heard Dr. Sandoval talk about this morning. We've done the work now, and that's why you're seeing us be able to increase panel sizes by 3,000 patients in the medical center, similar percentages sized across the network. We understand that we have issues there, and we've worked very hard to start making a difference, but we're not done yet.
So what percentile goal do you have for the special? I saw something I know you're switching how you think about the primary care practices, but I'm interested in the specialty practices in particular. What percentile goal is set for clinical productivity?
I don't have the most current physician contract at the tip of my fingers. Rick, do you know what we're using right now? I don't want to misstate it. Oh, go ahead, Judy. You're on mute. Go ahead.
We're targeting the 50th, P50.
Yeah.
Is that what's budgeted or is that what's targeted? What's budgeted in terms of productivity?
I have to look at the detail of that. So we are, and you'll see it in the worked RVUs, we are budgeting at that. So you are seeing an uptick in the worked RVUs as a expectation of increased work effort.
So the expectation is that across all those specialty practices, that the average for the practice will be at the 50th percentile in 2025? The work RVUs?
In general, yes, I would say that there's certainly an opportunity for that to vary depending upon patient demand, availability, provider availability. But yes, general expectation, yes.
Okay, I think there was a chart somewhere that had work RVU amount in there, and there's so much paperwork around here. I would love to see that breakdown a little bit more detailed on to make sure that I understand how much of the utilization expectations is coming from an increase in productivity and expectation around productivity. That would be really helpful.
All right, and we do have Brad Crump, who will have much more of a detailed information on our medical center and what we're focused on in that area. And Brad, have you been sworn in?
Yeah, I was sworn in this morning. Good afternoon,
Right,
everyone.
thank you. If you can take just a moment to
Hello.
introduce yourself, and I think you'll be a good asset to this to answer some of these.
Yeah, absolutely. Appreciate the question, Member Holmes. So I'll just qualify one thing Judy said. So to your point, we don't budget at the 50th percentile. We budget at what we predict is possible, given constraints. To Dr. Leffler's point, the work we're really moving forward on is how do we free up providers' time? Primary care being the obvious example that we're working on with plans to work on, specialties throughout FY25 and FY26. The qualifying point, though, is in the budget, where Judy stated the target is the 50th percentile. I would qualify that specific to the UVM Medical Center, where we have specialties where we don't, subspecialties where we know we don't have the volume. And that's the classic challenge where we're kind of indirectly hiring for call, right? You can't have people being 1-in-1, 365 in call. So if you take out those things like some of the pediatric subspecialties, I think then broadly you can say that absent those, the target internally is to move people towards the 50th percentile.
Okay, so if I understand the clarification, the target is to move the practices towards the 50th percentile with some exceptions around volume, but that it's not currently budgeted for the 50th percentile. It's budgeted for less than that because it's not currently possible to reach the 50th percentile in 2025. Is that right?
Correct. Not currently predicted. So our budget is an attempt to put forward what we think will occur.
And so what percentile is that?
I'd have to get back to you with, the exact numbers per specialty.
Okay, that would be helpful. I was also looking at, just sort of added up the non-APP categories in that productivity document, and I was struck by the differential between the clinical FTEs and the total provider FTEs. So I think there's around 460 clinical FTEs, but there's 660 total provider FTEs. And I was wondering if you could talk a little bit about that difference. Like, take one, for example, there's like pulmonology where there's 10 clinical FTEs, but there's 18 total FTEs. So I'm just wondering, whoever's
Yeah,
doing
absolutely.
that.
So
Elliot, nice job.
yeah,
Thank
thank you. I think as, a few folks spoke to, that is, one of the unique factors of an academic medical center. As you have a physician, let's call them hypothetically a 1.0 FTE, that physician is going to do multiple activities, research, education, teaching, and clinical. So you're absolutely right. In academic medical centers, you'll see that larger differential between the total FTE and the clinical FTE.
And is this differential compared to other academic medical centers about the same, median, above, below? Have you benchmarked that differential?
I'm not sure if it's been benchmarked. Does anyone on the team know?
No, it's not been benchmarked, and I don't know if that benchmark would actually mean anything because there's different levels of research activity and non-clinical activity. It fluctuates across academic medical centers. I don't think that benchmark would even tell us very much about that differential.
Well, does it tell you anything about revenue potential that could come other than through commercial rate?
One thing I'd call out though is in the differential, what we call that non-clinical FTE, the delta between the two, there are funding sources in there, for research and those sorts of things. And that gets back to the point made earlier today.
Right. I guess what in part, I'm trying to understand opportunities for revenue enhancement that don't involve commercial rate, right? Because we've talked about the affordability crisis that we have in Vermont. We've seen the rates that are, happening on the insurance side. We understand what's happening to people who cannot afford their medical bills. So we're trying, in my mind, I'm looking at some of this data and seeing, is there another revenue opportunity with increasing throughput, particularly in areas that have long waits and relatively, and I say relatively, relative to benchmarks, low productivity, or a big differential between the clinical FTE and the total FTE, right? These are presumably staff that have been hired with clinical expertise that could potentially be seeing more patients. They've already been hired. Their salary is already baked into the budget. Could they be increasing revenue for
So-
UVM, reducing wait times
Member
at a
Holmes,
lower marginal cost?
yeah, so I think the lower marginal cost is probably true, but when we hire those individuals, so you could pick any one of them, you might hire them to only work 0.8 FTE. They're still a one person, a 0.8 FTE, because he wants to spend 2 days at home taking care of his children. And then he's coming in on a research grant, and that's part of the reason that he's coming here. So that's another 0.2 to 0.4 that you're pulling out. And now they've got the 0.4 of a clinical FTE dedicated to doing that work. And that's where the dollars are going from the commercial payers, the Medicare, everyone. If you were to increase that person, let's say he says, I'm gonna come to work, I'm gonna hire a babysitter now, and I'm gonna work all 3 of those days. Well, and actually sees more patients, well, more revenue would come in because he'd be seeing more patients, and that would be NPR would go up as a result, and that'd be a mix of all of those patients. I think you're right that the marginal cost of that is probably lower than hiring like if you had to hire a new person, right? So I think you're right about that. But the reason that they come to work here in that way is because that's what they want to do. And if we said to those 18 pulmonologists, now you're going to have to work a full FTE clinically, they'll be like, no, thank you. We're going to go someplace else to do that. So I don't think that's the right place to look for that. I think for us, the way that, and Brad, please help me out on this, the way that place that we've been, and I can talk about the complicating factor on the specialists in a little more detail, but in primary care is where we've really tried to take this on, I think in the way that you're suggesting, which is we're paying at the 50th percentile. Ought we be able to get 50th percentile work RVUs or whatever measure we're going to use to do that? And that's where we've been focusing on our efforts. Part of that is by doing what Steve suggested, which is let's make sure we get all the support that they need to be able to perform that. And so we know that we have obstacles there. And the other part of that is some of the work we've been doing around defining their patient panel and looking at how complicated their patient panels are, and then determining in a standardized way, here's how many visits you ought to be able to be delivering based on that patient panel, and then opening up panels, really just algorithmically. And that's the work that we've been doing, really focused on primary care as the first part. The specialists are more complicated, and we can talk about that more if we want. So our first step, and I think Brad was alluding to it, is we need to do this incrementally, take those steps to get there. Our goal is to get to the 50th percentile without driving people out that we think are good clinicians, and making sure that we're providing the support in order to be able to do that. And so I think hold us accountable. Like let's figure out a standard measure for how we want to look at that and how we're paying, and totally collaboratively work on what that is, and then hold us accountable to getting there. I think that is real, and that's what we want to do. And that's where we have really been putting our efforts. So there's a lot of work there, and I'm not dodging the issue. I think there is opportunity there, and I want to go after it. But part of that is we have to standardize all the schedules so that we can make them all the same, and people have expectations of what that will look like, provide that support staff, and then bring people up to speed, because that's not the way they've been practicing. And do it collaboratively so they don't leave, honestly. And so that's the challenge for us to do that. Brad, please, you're much closer to that work, but
I just want to add one more important point. So Member Holmes, you have to remember that we have 3 missions, and with the Green Mountain Care Board, we're very focused on our clinical care mission, but those 18 pulmonologists among that group all have missions of teaching our residents, medical students, all the learners. Many of them have research grants from the NIH. And so we want to make sure all that work is getting done. If we just said it's all 18 of them, just go work clinically, yes, we would get more patients through, but we wouldn't be meeting the other critical parts. Those pulmonologists are over at medical school today teaching students about lung physiology and pneumonia and COVID. And so they're not available today. And other ones, those 10, so the 18, many of them have some different parts of their task. And when they're teaching at the medical school, they get paid from the medical school for that. When they have NIH funding, they're getting paid from that source. So it's part of the bigger mission. But I understand your point. Yeah.
No, I understand that. And I want to make sure that it's clear. I'm not highlighting the pulmonologist. I gave them as an example. I want to fully recognize that it was not really unique to the pulmonologist, and I'm sure they're doing fine work, and I appreciate that. I appreciate also the mission of an academic medical center and educating our next generation of doctors and doing the research. I also want to say we are in a crisis. We're in an affordability crisis, and we're in an access crisis. And so how do we prioritize people's time for the greatest impact? And for now, my focus, you're right, is on affordability and access and quality, which we can, we're probably not going to spend too much time on. But so, as I look at this budget and I look at the ask of this budget, it's a big ask in terms of commercial rate in a time when we have an affordability crisis. So I'm looking at other opportunities to do that without going to commercial rate. And I see opportunities in revenue enhancement at lower marginal cost through clinical productivity. So let me just ask a couple more questions on this, and then I will.
Member Holmes, but you do recognize that, and we're arbitrarily using the pulmonologist, but if we move them to more clinical FTEs and they generate more revenue, that will increase the NPR. Like, people are paying for that, right?
Yes, I understand that. I fully understand that.
Yeah.
Yes.
So that's the balance. So if we want to improve access, and that's what we're trying to do, that's going to improve NPR. So I guess we have to all accept that part. I'm not sure if we're all there yet or not, but yes, absolutely.
I think we have to.
True.
Yeah. Well, we'll see where we're all there, where we all are.
I might just add one other piece of this discussion that I think is getting missed in this. So So in Sonny's example, he highlighted that there's an opportunity potentially on the, productivity side, but Member Holmes, you've been asking about the total FTE to clinical FTE gap, and is there an opportunity there to, redeploy to where it's most needed? I just want to highlight that because that, that difference when you look at individuals is getting funded in a different way. As that shifts, in addition to increasing NPR, it also increases clinical costs because that physician now is going to be paid through clinical dollars versus grant
Research
and teaching
dollars.
dollars that they're being paid for now.
Yeah, I understand. That makes sense. I noticed that there are 43 vacant MD positions proposed in the fiscal year 25 budget, and I'm wondering how does some of this clinical productivity conversation that we're having right now and the need really to staff and help support the existing MDs to improve clinical productivity impact the decision about whether or not to fill all of those vacant MD positions. That's pretty expensive, I would
Brad?
think. 43
Brad?
new docs. So I'm just wondering.
Yeah, so if I understand the question, it most likely doesn't. The way we budget is we budget vacant physician positions for what we call our capacity services. So anesthesiology, emergency medicine, where we know we're going to need a certain amount of capacity of clinical coverage for those areas. And when we don't budget those vacancies, we are paying for those anyway through paying our current physicians extra shifts. So the dollars predominantly come out in the wash. Separately, where we're recruiting for what we call productivity physicians, you think about, orthopedics, GI. If we don't have a signed contract, we do not put those in the budget because we don't want to create a situation where we're putting in additional revenue that may not occur absent actually filling that position.
Okay. All right. I think my other colleagues on the board may have some more questions. I'm going to move on because I have a couple more questions and I realized I've taken an hour up. So a few more points and questions I want to ask about, and then I'm going to pass the baton. And this is related to both the narrative and the presentation relied pretty heavily on the Dartmouth Health Atlas and then Professor Cooper's research as evidence that UVM is a low-cost provider of medical care for Medicare beneficiaries and the commercially insured. And so I just wanted to talk a little bit about that. The estimates of the low spending per Medicare beneficiary, that comes from the Dartmouth Health Atlas. I think there was a slide up and I'm wondering, using that Dartmouth Health Atlas, can you discern actually between low per capita spending because of efficient clinical protocol by UVM, because of efficient clinical protocol by non-UVM providers, or low spending because we have access to care barriers?
So we haven't dug down to that level, Member Holmes. I don't know if that is possible or not, but certainly not something that we've dug deeper into.
Okay. The other piece that I would just say is the Dartmouth Health Atlas, the data that we just put up there, that's from 2019, which I think is the last time that they did it. How would you expect that number, the per beneficiary Medicare spend to look now after more recently, given the Medicare sole community hospital rate bump, UVM's efforts to increase their case mix, CMI measure, the increased access initiatives that you've been talking about? What impact is that going to have on relative Medicare spending per capita now? And how do we assess that?
So I can start. Maybe we can pull up slide 52 just so we can focus in on so obviously that the Medicare, the Dartmouth Atlas data is 2019. The Cooper analysis is a little bit newer data, and it, as we tried to highlight, it's telling the same story in terms of Medicare. If you look at the chart on the bottom left, and you look at the Burlington hospital referral area, it's in the bottom quintile of their analysis. In terms of the impact that the rate increases are going to have on the, that analysis, we haven't done that, but knowing just how low we are and this is 22 data, it certainly will have an impact, but taking us from the bottom of the quintile to above the median, that there's I can't see that would because we're not, at the end of the day, we're not talking about huge dollars. Judy, the impact from this whole community hospital was what, around 9 million or so.
Yes.
Still to be determined, but again, we're starting from such a low place that even an increase would still keep us fairly low on a total cost of care perspective.
Okay, I'm glad you brought this slide up, actually. Do you know the year of the data that was used in the Cooper 2022 paper? Well, I'll just tell you, it's actually 2017.
Oh.
So this 2022 paper actually relies on data from 2016 to 2017. So it's even older, actually, than the Dartmouth Health Atlas. And the 2015 study that I know you cite in your narrative is actually relying on 2011 data. So both the Cooper papers are really, really outdated, both in terms of commercial spend and in terms of Medicare spend. So this does not actually address the question of what's happening now at all, unfortunately. This is pretty outdated data. It takes a really long time in academics to finish a paper and go through the publication process. So that's a problem with academic studies. I also just wanted to bring this up because I'm glad you brought up the Cooper analysis, because you cite it not only in the narrative, but also in the presentation and here. In particular, I think the narrative states, Cooper's 2015 paper shows that Burlington is in the second spending quintile nationally. So while it's one of the least expensive Medicare regions, it's also among the lower cost commercial areas. That's again using 2011 data. But also, are you familiar with the sample that Cooper used to estimate spending for the commercial population?
So this was actually an analysis that was presented, I believe, at the Green Mountain Care Board last year, correct?
Yeah. Yep. No, he did present some work. Absolutely. I'm just wondering if you've read the paper and understand the sample that was used for commercial.
No, we don't. I don't
No.
understand the sample that was used for the commercial.
So I'll just share it with you. It actually, it only uses individuals that have employer-sponsored coverage from Aetna, Humana, or United Health, because it relies on the HCCI data set. So the commercial spend is only about 6% of the Vermont commercial population back then in 2011 or 2017, whichever year you choose. So, and presumably those three carriers probably have the most leverage in negotiation and the most sophisticated utilization review. So they may not be representative of the commercial spend of our population. So I guess, my point here is this is some data. It's certainly been presented to the board, but UVM is relying on it to show that UVM or the hospital service area is a low-cost commercial area. And I'm just wondering if you have any more evidence, more recent evidence, that's more comprehensive in terms of the population of commercial payers or commercial population, that actually points to UVM's as a relatively low-cost provider of care for the privately insured. I'm looking for that kind of evidence.
We can certainly do some more research and find something that's more appropriate that we can share with the board.
Okay. That would be helpful. And my last couple of questions are just around price, because I think that's another way to assess whether UVM is a low-cost provider, is to look at price. You know, there's plenty of research out there that shows that price growth is the primary driver of healthcare spending growth. So if we understand what's happening to prices, we'll have a better understanding what's happening to overall spend. You mentioned in the narrative the Clarify price transparency subscription that you now have access to. And there was mention of one service where UVM might be cheaper than other AMCs. I think it was knee replacements. I'm wondering, what is the rest of the Clarify data reveal about UVM's pricing? Particularly, I'm really interested in the outpatient pricing. So I'm wondering if you can talk a little bit about that Clarify subscription that you have.
So for that, I think Kelly's on. I don't know if you can add.
Sure. Hi, Member Holmes. So first, I will note the Clarify tool we only recently had, and much like the transparency data, I just want to caveat, it's based on what the payers and hospitals submit, which is getting more robust and updated quarterly. So what I say here, I want to just put the caveat of new tool subject to further edits. When we provided the knee and hip comparison, again, it gets to actually the conversation earlier with Chair Foster on how different services are priced differently. And we do look competitively, if you will, lower on certain areas. And then others we are higher. And what the transparency tool is actually allowing us to do, to look at where we are within regional comparisons and see where we can make adjustments. I think that was mentioned earlier, is when we looked at affordability, what can we do, and where we are out of line with prices, which we should define on what price means. There's the price to the employer, the insurer, and the patient. And so what it does show is how much hospitals may get reimbursed by a payer. So I'm going to level set there. And it does show variation, and it shows variation between payers. So on outpatient, we are higher, which I think has been, shown in the other studies, that the outpatient services, though, when they're both together, look higher. And one example we found is, again, dialysis is considered outpatient than we do, where other hospitals in our area don't do outpatient dialysis. That's done by another provider. So it gets into needing to go into the detail, which now that we have this tool, I'm excited to say we have more visibility that otherwise we haven't seen. So we can do our comparisons within our budget and see where we can perhaps address on our side the affordability by looking at cost share from patients in terms of how much the insurers are paying.
Okay, there may be a follow-up ask. I have to think a little bit about it, what that might look like with respect to that tool and what you've learned, but I want to think about what that follow-up ask would be. And I'm going to just, close on this pricing issue with the RAND pricing, which I know there's been lots of back and forth about, and it is one measure of prices, similar, as you said, Kelly, there's multiple ways to look at prices and defining prices, but it is a tool that's helpful to us to review. And I understand the issues around the Medicare relative pricing, but when we look at the standardized pricing, I think we've seen that on inpatient, middle of the road, but on outpatient, extremely high for the medical center. And even I took the list of the 16 comparator hospitals that were in those 2 pages and looked at what their standardized prices were for outpatient services. So for other AMCs and large community hospitals in New England, right, the median and average outpatient standardized price was in the low 300s. And UVM's was over $500. So that's a huge, huge difference in standardized price, whether we look at the RAND, whether we isolate it to just the comparator hospitals in New England. And I heard what you said, that you think that it's a difference in, what either the service mix or the site mix, something like that. I would love to see a little more evidence to back that up, to support that the types of services that are going to be considered are different. I would like to understand that more. And I would also like to ask, given that your outpatient prices on various measures are high, you're asking the board to approve a 7.9% rate increase on outpatient, on inpatient, and on professional services, if I understand correctly. So how does this relative price factor into that uniform rate increase across all those services? Why not recognize that you have really high outpatient prices on a vast majority of those services, presumably, and lower the rate there?
That a question? I just want to make sure that's
It's a question,
for you.
and
I
you,
didn't
I don't know if
that
you're the
was
one to
just,
answer it. That
yeah.
might be for Mr. Vincent or somebody else. I don't know, but I'm wondering, how do you factor in those relative prices in the ask that you're making in terms of inpatient, outpatient, and professional?
Okay, I just want to again make sure we had the question, and Rick, I can answer that if you're. At the time, it gets to partly budget timing and somewhat to my conversation earlier, budget submission timing, and then when we're in the modeling and negotiations with payers. So with, the board does approve our budget ask of the 7.9. What we do work with the payers, and if on outpatient is higher, there could be adjustments there. And that's actually some of the work we do with the payers. And some of the payers will bring those pricing adjustments to us. And what that is, really focusing on where they want to change certain things. So one payer has said on the inpatient, I'll focus on inpatient because it's an actual example. Your DRG is too high on this pediatric or OB service. So we've adjusted that. So we get to that detail, and that's certainly part of the conversation, especially as we're looking at radiology and some that we have seen that we are higher. So that does happen to get to that aggregate 7.9.
Yeah, but it just means that something else is going to be higher. So you're going to say, okay, but we want more on some other service, right? To get to that same aggregate versus saying, how we're high here, we'll lower this, not without some commensurate increase somewhere else.
Yes.
I mean, it's partly because we're low in other areas, right? That would be lower than the 160% or 200%, whatever the benchmark is. And so I think you're right. It is a combination of all of those things. I think we don't typically look at it at the aggregate. The other challenge we have on the outpatient side is that compared to most of the Northeast, certainly in Massachusetts, we just don't have a lot of ambulatory surgery centers that exist. And so when you look at those comparisons, particularly from payers, if you look, we don't do them here. That's part of the reason we need the surgery center. It will drive that number down by and large by doing that. But when you do the comparisons, we're doing those in the hospital at a higher cost. That is true. And so again, it's sort of a little bit of, I would say, outside of our control in a way, because it does cost more to do those things inside of a hospital than it does in a freestanding surgery center, I think. So that's also part of that. So.
Okay, that's helpful. My last question is actually a bit anecdotal, but I'm curious about it. We've talked a lot about access barriers, and as you probably know, I've been concerned about wait times for several years now, and concerned about access. I think wait time data is important. I also think it's probably an underestimate of actual wait times. I think referring providers know it's difficult to get an appointment at UVM, so they don't refer anymore. So it's possible that wait times are a potential underestimate of potential revenue that UVM could generate if throughput could be improved and clinical productivity could be improved. But I'll also say this is a personal statement, but I'm going to share it anyway. I called for a procedure in July, and I was told by the scheduler that providers were scheduling into November. That was 4 months out, but they couldn't schedule an appointment for me because the November schedule would not be available for another month. So I needed to call back. So it sounded to me like the schedule was only set for 3 months at a time. And I was told to call back in a month when that next available schedule would be, up to date. So having that experience, I'm just wondering how we think about the submitted estimates of wait times, if that are going out 3 months and 6 months, if people are told to call back within the 3-month scheduling window, wouldn't that mean that close to 100% of patients or near that would be scheduled within the 3 months? Would that be an accurate representation of waits, I guess, is my ask.
Brad, are you able to take that?
Sorry, I was searching for the camera, but first, member Holmes, I do apologize. I think your anecdote is fair, and we hear anecdotes like that, and I think we're all patients in the community. I think your general assessment also is fair, recognizing that what we submit are wait times based on data that's in our system. Going back to the discussion about standardizing schedules, and that work that we're undertaking, that is part of it. We do have variability in the practices in terms of how far out people are putting their schedules based on a multitude of factors.
Okay, so for some specialty areas, the estimate of how many patients are seen within 3 months may be wildly off if they're told they have to call back in another month or 6 weeks to actually make that schedule.
I think using your anecdote, that math would make sense, yes.
I was told 7,000 people were in that category, actually, by that call. 7,000 people were going to have to call back. I don't know if that's accurate for that procedure, but that's a lot of people. With that, I'm actually going to pass the baton back to Chair Foster, for whoever's next. But thank you very much. I appreciate it. I learned a lot, and I look forward to some follow-up. Thank you.
But one quick follow-up on that, 2 quick follow-ups for myself. Is that a new policy that you call back before you can get on the schedule?
Chair Foster, it's not a new policy. There is variability, and where we're working towards is really targeted areas. For example, in the FY25 budget, looking at colonoscopies, where we recognize there's a huge backlog and running some sprints to move through those.
Okay. I'm concerned it really does throw off the wait times information and the access information that we're trying to rely on to make budget decisions. So we're going to have to dig into that and make sure we actually understand it, because that really changes the data significantly. Other quick question, I just want to make sure I understood this. The NPR request is 8.6, as I understand it, and the rate increase is 7.9 requested in this budget. Is that right?
I have it written down at the very end on page 58. Is that, want to pull that up? I just want to make sure that we're talking about the same thing.
Yep, on slide 58.
Elliot, will you throw that up, please?
Right. 9.3 NPR, 791 rate. And that 9.3 NPR and that 791 COM rate is off of projected 24.
Projected 24 informs the basis for our FY25 budget. It is not cumulative, so there are variables from FY24 to FY25. It doesn't just build on current rate forward.
Okay, so let's go to the 9.3. The 9.3 NPR increase, that is a 9.3 NPR increase off of what?
The 24 budget.
The 24 budget.
I'm trying to get that slide up.
Okay, and then similarly, the 7.91% commercial rate increase is a increase above what the Green Mountain Care Board approved for fiscal year 24 budget.
It's not in addition, it is the request itself. I just want to be clear on that.
Hang on, I got to make sure I get this right. I apologize. I should have picked up on this a long time ago. You submitted a budget in 24. We approved a budget in 24. And then this request for 25 is 7.91% commercial rate increase off of what the Green Mountain Care Board approved for fiscal year 24. Correct?
Yes, these are budget to budget comparisons. That's
That's
the
what I was trying
guidance.
to pull. Thank you.
Yeah.
Budget, approved budget.
Correct.
Great, okay. All right, why don't we take a 6-minute break and come back at 3:30 and we'll continue. Thank you.
Off the record. It's 3:30. Michelle, you all set?
Ready?
Okay, Dr. Epen, you guys good? Okay, great. We'll resume our hearing of August 28th. We're in board member questioning, and I'll turn to Dr. Dave Merman. Would have asked if Dr. Dave Merman is back. Try and send him a message. Oh. He's having an issue with his computer. Why don't we skip to member Walsh or member Lunge?
I can go. Um, so first off, let me just get my notes pulled up and get everything where I want. I wanted to first start just by thanking you for the presentation, and I particularly enjoyed or appreciated hearing the work that you're doing on affordability, the work with Milliman, and looking at the system level, the network level, site-specific changes to improve affordability for Vermonters. I also appreciated the conversation that you had with Owen about the cost shift, and I have some questions coming up about that. I'm still going to ask those, but I wanted to say up front that I heard the conversation you all had, and I look forward to talking with all of you more about it. So having said that, in your narrative, you talked about wishing that the board used a per capita expenditure calculation. The Medicare MIPS has a total per capita cost for clinicians who are not part of all payer models or alternative payment models. Are you familiar with the total per capita cost calculation?
I'm familiar with MIPS. I haven't studied the calculation of how they do it. I understand what MIPS is.
Yeah, well, it's pretty simple. It's for every clinician who's participating with MIPS, it's a total of Part A and Part B spending divided by the beneficiary months, which is kind of a complicated way of recognizing that beneficiaries move into the calculation as they become 65 and they move out as they go into Medicare Advantage plans or they die. But that's the numerator and denominator. So Part A plus Part B spending. And are you familiar with any of the limitations to that per capita type of calculation?
Please share.
No, I don't think we are. I'm sorry if we missed it. Was it in something that we should have looked at or seen? Or
Well, in the narrative, the opening of the narrative that you sent, you argued kind of persuasively that we ought to include per capita cost or per capita expense in our way of assessing your performance, and that using the commercial rate increase or the NPR growth, that those may not be the best things to be monitoring, that it'd be better to use per capita expenditures. And that's been discussed a few times today in this discussion, the use of per capita. And Member Holmes spoke to this a bit ago, that the biggest limitation to the approach is that if you have a community that has a lot of medical debt and care is very expensive and there's access issues, the total cost per capita calculation is going to look pretty good because people can't get in or they're choosing not to. And so we don't use that calculation in this environment for that reason. And I wanted to explain that. It wouldn't give an accurate representation of the system that we're in. I want to just I don't have very many questions, and I want to try to keep them pretty direct and not a lot of commentary from my part. I want to turn to your balance sheet. Assets grew from 1.8 billion in 2020 to about 2.1 billion in 2024. And liabilities increased from 804 million to 837 in the same period of time. But then turning to your income statement, that doesn't go back to 2020, it just goes from 2023 actuals. So we're looking at just 1 year of actuals. And I'm wondering why the income statement doesn't extend back further. Why just the shortened period in the income statement compared to the balance sheet?
Member Walsh, is that something are you referencing something that's an adaptive or something that we've submitted? Is that something you could possibly put on the screen?
It's the income statement and balance sheet that you submitted to us.
I think it's on the screen. Do you mind restating your question?
Yep. So here we're looking, I think this is the balance. I think this is the balance sheet. Then if we could, and it goes back to 2020, the budget. If we look at the income statement,
Can you click on the P&L, Elliot?
Yep, I think it was there before.
so it's not the
Isn't this the profit and loss or income statement? Or
Yeah.
no, am I?
No, it is. Yep.
there may be a problem with version control. The one, I don't have it pulled up in front of me. I have my questions. The one that we received in the binder that I have begins with 2023 actuals, includes 2024 budget, 2024 projected, and 2025 budget.
Wonder
Yeah,
if
I believe-
Kristen, could you pull that up or no? Do you know?
I have the income statement that's listed underneath UVMMC. Let me throw it up on the screen. Is this the one you're looking for, Tom?
Scroll to the right.
Yeah. No, I think it's a version control problem. I think the one so is it possible?
You know, we could do, Tom,
Yeah.
I sort of threw you on the spot because of
all right.
Dave's issue. We can just go, I think Dr. Merman is back if you want to pull this.
If I
I'll put
could-
you Yeah.
No, if I could share my screen, I have it. Or, Kirsten, I can send you the link.
Is it this one? Member Walsh?
Yes. Can you make it bigger? Yes. Is that the one that I should have been looking at?
So these look like they're from Adaptive, and the one that was up on the screen a little earlier, there was a P&L on there, and it did go back to 2020. It looked like.
Okay. So this is, if you go back one, Kirsten, this is the income statement in the binder that we had. Right there, balance sheet and then income statement. So my question, and we've used way too much time on this already, was why so few years in the income statement? But maybe that's the wrong income statement to be looking at.
Yeah, like I said, I think there was one that flashed up on the screen a little earlier that looked like it was from Adaptive as well. That was from 2000, that went back to 2020.
Okay. Would these numbers for 2023 to 2025, would they also be accurate? Are they what would have been in the other document with more years?
Again, these look like Adaptive reports, so I can't speak specifically. Perhaps the Green Mountain Care Board staff can answer that question and whether or not these are both the same data sets for the
Okay.
reports.
All right, then I've got a couple questions that doesn't seem like it's worth asking about right now if we can't be sure those match with what you have. So let's move on. Thanks for your patience. You had comments earlier, comments of criticism about the RAND data, if we could shift focus to that. And you referenced an American Hospital Association's comments about RAND in Appendix F. And I have a simple question. Do you know of a peer-reviewed criticism of the RAND data or cite another commentary from a healthcare economist, health policy scientist, or anyone else without a strategic self-interest in the results? Anybody other than the AHA?
I don't know any. I don't know if anyone else does.
Okay. Member Holmes asked some questions about the RAND data. She talked about the break-even price. Yours is at 216% of Medicare. The national average is 122. Another way that we use the NASHB calculation is to look at the gap between the total facility price as a percent of Medicare to the break-even. You have a gap of 115 points. A couple other hospitals in Vermont have a gap of over 100, but we've also seen hospitals much lower with a gap of as low as 11 in the state. And again, that's supposed to represent productivity and efficiency. And in your conversation with with Jessica in talking about the break even and Medicare data and with the RAND, you mentioned that Medicare pays different hospitals differently, and that may be some of the difficulty that you're seeing with the RAND and NASHP data. Did I hear you correctly about that?
Member Walsh, I believe that's one component of it. I also think that services offered also plays a role. So the UVM Medical Center provides dialysis for the whole state of Vermont at a huge loss. That's not that common in academic medical centers, actually. We provide psychiatric care. We own primary care. We do many things here because it's part of our overall mission to the state and our patients that lose money. So I believe that is a component of, I think, of this as well.
Okay. Medicare does pay different facilities, different reimbursement levels. Why is that?
Medicare tries to manage or cover the costs or adjust for the cost of where the care is being delivered. So there's things like the wage index, but once again, I want to be honest, you're going to be above what a doctor understands on this pretty quickly. So I want to give it over to my CFOs, thankfully here, to give more detail on that. But I do understand they adjust to the expense to some degree, not perfectly.
Yes, they do make that attempt, but as you saw in some of our data, it's not always real time and it can certainly be outpaced. Medicare is always looking at, a couple of focuses on, the utilization and costs paid. But, it's never going to be a perfect match. And Vermont does have some unique challenges that certainly impact our Medicare population. I know, Rick, you were going to say something as well.
I was just going to highlight those same slides that we highlighted in the presentation, Member Walsh and Judy, that the wage index definitely plays a pretty big part in the Medicare reimbursement, and how that's set, and the way that it's set for us is definitely different than it is in other parts of the country. A much more detailed conversation, but the entities that factor into that wage index is different in different parts of the country.
There's the wage index, and there's a rurality adjustment, academic medical center adjustment. Those, as Steve was mentioning, those are attempting to adjust for the underlying cost in the region. And so the differences in Medicare reimbursement are a feature, not a bug. It's not a problem with the way that they're doing it. They're trying to equalize things, so more apples to apples across the country. And you went through in your narrative, you talked through your findings about RAND and NASHP, your concerns, and also about Medicare cost reports. Is it your assessment that the findings of high prices, high administrative overhead, low efficiency, low productivity that are in RAND and NASHP and the Medicare cost reports, all of those things are fundamentally flawed when it comes to understanding what's happening at UVM?
I believe that's where you start the conversation. I believe that the value is in starting there and then understanding where we're similar, where we're different. And so you have to go beyond column 2 to further look into the data. I also think that every AMC in the country is unique and has very unique things around it. So you can compare at some level, but there's always details that have to be included in a comprehensive understanding of what your situation is, what services are provided, how rural are you, what other hospitals are nearby that you can shunt patients to potentially. Can you go on divert? It's impossible in Vermont to go on divert. We have 25 boarders in our ED right now. My screen is going crazy with trying to manage everyone downstairs right now. So we're going to bring in a bunch of extra people tonight and pay double time and staff our hallway in the back that I walked with Chair Foster one afternoon. It's completely full of patients right now. It's going to be expensive tonight at the medical center. That's what we need to do. So to answer your question, I think the reports have value, of course. I think the real value, though, is having a meaningful, productive conversation about where do we look similar, where do we look different, where can we learn from them to be more efficient going forward. We're a learning institution, absolutely.
I'll just add, Member Walsh. So in terms of administrative costs, I just want to make a definitive statement. Yes, we do, based on multiple different data sources, we believe we're efficient. Now that the NASHB data, when we're looking at admin to clinical salary ratio, it's not flawed, it's just incomplete. There's one extra step that could be done to actually, our data is actually more accurate than many other hospitals that are part of a system. That's really where the inaccuracy lies. If you go back to those slides that we presented, our number actually doesn't change a dramatic amount, but it's all the other organizations that when you look at NASHB, the amount of administrative salaries to clinical salaries, for example, just look down through the list there. NASHB says that St. Francis is at 1.8%. They're actually at 42.3% when you include their home office cost allocation. So it's not that it's inaccurate, it's incomplete. So from an administrative cost perspective, yes, the data points that we've looked at, whether it's this, Centellus, and others, we believe that we're efficient. In terms of RAND, I do think there's something in the outpatient analysis that we need to better understand. There's likely a price component to that, as Member Holmes highlighted, that we need to understand. There's definitely a service mix piece. So that one, we still need to do some more research to better understand. The inpatient, I think we've kind of highlighted that we're actually we're in a reasonable place there on inpatient pricing, and the relative comparison is actually going to start to look better as our Medicare rates start to go up.
Okay, I appreciate that, and I appreciate I want to learn more about the technique that you showed for calculating those administrative expenses, and I'm interested to see if there's more administrative expenses assigned to the parent organization. Do we see savings in the affiliate organizations? And you'd expect those savings to materialize at some point. So thanks for that explanation. And I look forward to looking at the table that you shared further and being in touch about that. I'd like to turn to elsewhere in your narrative. You talked about the cost shift, and Owen asked questions about that. You cited an article that recognized the cost shift and criticized past research on the topic because those past studies are retrospective studies. I'm wondering what would be a better method for that type of work if you could design the study yourself.
Well, I'm not sure if I can completely answer that, but I will just say that I think this regulatory body, I suspect, has seen a level of transparency in terms of the cost shift, probably unlike any other regulatory body in the country. When others come forward with the rate increase one, there's not, there's other states that don't have the process that we have here in Vermont to be able to kind of really see the cost shift. For us, the slide that we've been, the data that we've shown for years now, we've clearly delineated, this is our cost inflation, this is what we're getting from Medicare and Medicaid, and then this is the piece that essentially the commercial payers are covering for what's not covered. So potentially a starting point is if there was that level of transparency in other parts of the country, you could start to get into the data to create a research study, if you will, that looks at the cost shift. But you would need the same level of data and transparency that we've been providing to the board for a number of years.
I see. So we're not sure what would be a better method for the research, but more transparency could be helpful. I agree with that. Is it true that all the prior studies were retrospective?
So the article that was quoted, it said that they were. That's the.
And the article that was quoted, what research method did that author use?
We can't answer that question. Sorry.
As you've talked about the cost shift, that would imply that hospitals with a higher percentage of patients with Medicare, Medicaid as the payer, those hospitals, because they had more patients with public payers, those hospitals would necessarily have to have higher commercial prices. I've understood the way you've discussed.
So not necessarily. Again, there's different amounts of Medicare and Medicaid across the country. There's different ways that the provider tax is allocated to Medicaid or to hospitals than it is in Vermont. So again, these are complex analyses to generate, but that isn't necessarily a conclusion that you could reach without doing a lot more digging into the details.
So some
What
hospitals,
the services that they offer also make a difference. There's Medicaid programs that bring Medicaid to commercial that could make a difference. There's a lot of things that could go into making certain hospitals do better.
I can give you just one concrete example that we know because we've seen this. Member Walsh, is you've heard us talk about hospital directed payments, which is an enhanced Medicaid reimbursement. We know because we've seen the data, the size of some of those arrangements across the country. So if you look at an academic medical center that has a very large arrangement, then no, they probably wouldn't need as much. They might have a large proportion of Medicaid patients, but they're getting a much larger amount of Medicaid revenue and wouldn't necessarily need the same amount of cost shift.
are Vermont's Medicaid payments relatively high or relatively low compared to the rest of the country?
The payments themselves, without any additional enhancements through GME or hospital directed payments, those are compared to other parts of the country are at a very reasonable level.
And have your prior budget submissions to the board included your estimates of the amount needed to cover underpayments from government payers? Have you put your calculation of the cost shift into the prior budgets that you've sent to us?
Yes, that calculation that you've seen, which I'm just going to refer to the slide. The Chair Foster spent some time going through. That's been part of our budget submissions now, I think, for 7 or 8 years. So we've made the calculation the same way for quite some time.
So has the board ever removed any portion of that estimate?
Has the board ever removed any portion of that? So can you say a little bit more there?
So has the board ever denied a majority of your request?
Yes, I mean there've been reductions in the commercial rate increase that that we requested. Yes.
And would you consider those reductions large or small?
It depends on the year.
And so in most of the data that I've seen in the last 3 years, the board has, it varies, the calculations can be a little bit off, but over 85% of the requests that UVM has submitted.
I'm not sure if that's the commercial rate or if that's the net patient revenue approvals.
Okay. It doesn't seem to me that the board has ever rejected your argument about the cost shift. We've approved a large proportion of the budget that has included the cost shift.
Again, it depends on the year. Some years it was, yeah, the reduction was smaller, and other years it was much larger.
Okay. You're requesting your over guidance with both the commercial rate and with NPR. If we were to approve both and revenue went up and prices went up, how would those additional funds flowing into the organization be used to address the community needs identified in your community needs assessment?
So our 2022 community health needs assessment, the top 3 categories that our HSA was focused on was inclusive healthcare, housing, and mental health issues. We're fortunate at the medical center that we have a committee of both hospital staff and community members who every year allocate a little over $1 million out into our community to really focus on CHNA work. We put out 1,030,000 last year, I believe it was right around there. We gave dollars out to 22 awardees. So that's very specific work. But on top of that, the work that we do in our community as an anchor institution is very focused on meeting the needs of our community. We're working downtown to try and help with substance abuse disorder and people who have xylazine wounds. We have multiple outreach programs. We're standing up a mental health urgent care with community partners. The work we do is we're here to serve our community.
Okay. Do you have specific priorities or objectives, key performance indicators that monitor how well you're meeting the community needs?
I mean, we follow the CHNA. We present that to our board as we're as you have to do in your nonprofit, and we do get results back from the community partners who have given investments. They come back and give updates on the work that they've done and the impact they've had, and then